My name is Lexi Murphy, and this is my Hemophilia A case study for the Advanced Physiology and Pathophysiology course for the University of South Florida. In this case, we're focusing on a 9-month-old male. The mother reports that the infant has been experiencing bleeding from the gums, recurrent nosebleeds, petechiae, ecchymosis, and intermittent blood in the stool. The peer-reviewed article on hemophilia from the Nature Reviews Disease Primers explains that in severe hemophilia, spontaneous bleeds are common, whereas in people with moderate or mild hemophilia, bleeding may only occur in connection with injuries and surgery. Upon further questioning, the mother mentioned that the child had significant bleeding following his circumcision as a newborn, and states that neither parent has a known bleeding disorder or has experienced any similar symptoms. On physical examination, we observed bruising on the left outer thigh and mild swelling around the knee joints. The same article further explained that typically children with severe or moderate hemophilia show easy bruising around 8 to 10 months of age. During the first year of life, and especially when crawling and beginning to walk, muscle bleeds and joint bleeds can occur. There are many diagnoses that can present these types of bleeding symptoms described by these patients' mother. The journal article in the Journal of Thrombosis and Hemostasis, there is a helpful flowchart designed to better sort through the various bleeding disorders. Although in this case, we know the patient has hemophilia A, there would be a few diagnoses to consider if I were seeing this patient in the clinic for the first time without a known bleeding disorder. In order of priority, we have disseminated intravascular coagulation, or DIC, a serious condition characterized by widespread activation of the clotting cascade, leading to the formation of small blood clots throughout the body. This excessive clotting then depletes platelets and clotting factors, resulting in a later increased risk of bleeding, which can be fatal. Von Willebrand disease is the most common inherited bleeding disorder, and it is caused by a deficiency or dysfunction of von Willebrand factor, which is a protein essential for blood clotting. This factor helps platelets stick to blood vessel walls, facilitating clot formation. Hemophilia A is a genetic bleeding disorder caused by a deficiency of clotting factor 8, which is essential for blood coagulation. This condition leads to prolonged bleeding and difficulty forming blood clots, especially after injuries or surgeries. Cirrhosis-related coagulation dysfunction occurs when advanced liver disease impairs the liver's ability to produce clotting factors, leading to an increased risk of bleeding. The liver becomes less efficient, resulting in decreased synthesis of proteins necessary for blood coagulation, such as fibrinogen and prothrombin. Vitamin K plays a crucial role in synthesizing proteins required for coagulation. Deficiency can be from an inadequate dietary intake, malabsorption disorders, or certain medications that interfere with absorption. Before going into the pathophysiology behind the state of hemophilia, it's important to recognize how the process of hemostasis works in a healthy individual. Hemostasis consists of 3 main phases: primary and secondary hemostasis, and fibrinolysis. The Cleveland Clinic has an information page that provides a good overview of the normal steps of hemostasis broken into these phases. Primary hemostasis, or what Cleveland Clinic refers to as platelet clotting, is the body's immediate response to blood vessel injury. After an injury, damaged blood vessel constricts to minimize blood loss. Once the vessel is constricted, the underlying collagen and tissue factors are exposed. Platelets adhere to the exposed collagen using a protein called von Willebrand factor. As platelets adhere, they become activated. This activation changes their shape and triggers the release of chemical mediators like ADP and thromboxane A2. These activated platelets begin to stick together, forming an aggregate, but this plug is loose and unstable. Secondary hemostasis begins with the activation of the coagulation cascade, involving a series of clotting factors. This cascade can be triggered through 2 pathways, the intrinsic pathway and the extrinsic pathway. Both pathways eventually converge into the common pathway, leading to the conversion of prothrombin into thrombin. Thrombin not only converts fibrinogen into fibrin, but also activates more platelets, amplifying the clotting response. The fibrin strands form a mesh that intertwines with the platelet plug, creating a stable and durable clot. As healing progresses, the body will eventually need to remove this clot. This is where fibrinolysis comes in. Plasminogen is activated to plasmin, which eventually breaks down fibrin and dissolves the clot. Overall, hemostasis protects us from excessive bleeding. When a factor is deficient or missing, or platelets are unable to function properly, a bleeding disorder can develop. The coagulation cascade takes place after primary hemostasis occurs. It is essentially a series of enzyme reactions that lead to the formation of a stable blood clot. It can be broken down into three main phases: the extrinsic pathway, the intrinsic pathway, and the common pathway. The Journal of Clinical Hematology published this diagram, clearly labeling the three components of the normal coagulation cascade, and further elaborates on the steps of it. The extrinsic pathway is triggered by tissue injury or trauma, as you can see on the right side of the diagram. When a blood vessel is damaged, cells from the surrounding tissue release a protein called tissue factor. Tissue factor then interacts with factor VII, one of the plasma proteins present in the blood. This interaction activates factor VII to factor VIIa, which is the activated form of factor VII. The factor VIIa, along with tissue factor, then activates factor X, which leads us to the common pathway. Next, we have the intrinsic pathway, which is initiated by certain endothelial components, or the diagram refers to it as an activating surface. When blood comes into contact with the endothelial surfaces exposed by injury, factor 12 is activated to factor 12a. Factor 12a then activates 11 to 11a. Factor 11a activates 9 to 9a. Factor 9a, along with its cofactor 8a, activated by thrombin, then activates factor X, just like in the extrinsic pathway. Now that both factor pathways have activated factor X, which you can see in the highest horizontal purple line on the diagram, they converge into the common pathway, which leads to the final steps of clot formation. In the common pathway, factor 10a along with factor 5a converts prothrombin, which is factor 2, into thrombin, factor 2a. Thrombin converts fibrinogen into insoluble fibrin strands, represented by factor 1 and 1a. These fibrin strands weave throughout the platelet plug formed during primary hemostasis, stabilizing it and forming a more durable clot. Thrombin also activates platelets, further enhancing the clotting process by recruiting more platelets to the site of injury. Once an injury has healed, the clot must be removed, and this process is called fibrinolysis. Plasminogen, incorporated into the clot, is activated to plasmin, which breaks down fibrin, dissolving the clot and restoring normal blood flow. Hemophilia A is an X-linked recessive disorder, primarily affecting males, as they are only required to have one mutated X chromosome to express the disease. According to the Nature Reviews Disease Primers Journal on Hemophilias, the F8 coding gene consists 26 exons. Positioned at the distal end of the X chromosome, long arm, XQ28, it encodes the mature 2332 amino acid F8 protein. Defective F8 results in hemophilia A. Our patient's mother reports that neither parent has hemophilia A, but often females can be carriers of the trait, and approximately 30 to 50% of hemophilia cases result from a sporadic mutation in the F8 gene. This disease, from the same article, provides a glance at the coagulation cascade in a slightly different way than the last image, but I found it helpful to portraying the pathophysiology associated with hemophilia A. The first section with the superscript A shows the normal extrinsic pathway, and the second section with the superscript B shows the normal intrinsic pathway. Factor 8 as a cofactor for factor 9 to activate factor X, which is necessary for the conversion of prothrombin to thrombin. Thrombin then converts fibrinogen into fibrin, forming a stable clot. Because individuals with hemophilia A are deficient in factor 8, there's an inadequate thrombin burst, leading to the insufficient fibrin clot formation. Hemophilia A is indicated in the image with red lines demonstrating the domino effect of the deficient factor 8. To further classify hemophilia A patients, the severity of hemophilia A is often categorized based on factor 8 levels. The Journal of Thrombosis and Hemostasis' Journal on the Diagnostic Approach to Mild Bleeding Disorders provides a table classifying the disease on the y-axis and the coagulant factor activity, with disease severity classified into mild, moderate, and severe on the x-axis. In severe hemophilia A, factor VIII levels are less than 1% of normal. In moderate hemophilia A, factor VIII levels range from 1 to 5%. In mild hemophilia A, factor VIII levels are between 5 and 40%. Understanding the role of factor VIII in the formation of a stable clot makes it easier to understand that the less factor VIII available, there is less availability for the coagulation cascade to complete and entirely, stopping bleeding. As the percentage of factor VIII levels increase, the hemophilia becomes less severe, as more factor VIII is available to complete the cascade. The Journal of Thrombosis and Hemostasis has a journal article on laboratory testing crucial in diagnosing and identifying the severity of hemophilia A. The Activated Clotting Time, or ACT, is a test designed to quickly assess clotting function. Blood samples are collected and mixed with a surface activator, and the time taken for clot formation is measured. ACT can be influenced by platelet count and hemodilution, therefore its uses are limited. The Activated Partial Thromboplastin Time, or APPT, is a standard test that is more precise. It measures the intrinsic pathway where factor VIII is involved. A prolonged APPT, along with normal prothrombin time and platelet count, often indicates hemophilia. Unfortunately, several factors can prolong the APPT, including other deficiencies in the intrinsic pathway and the common coagulation pathway, and mixing studies may need to be done to determine if the prolongation is due to factor deficiencies or the presence of inhibitors. To officially diagnose hemophilia, we need a functional coagulation assay that measures factor VIII deficiency. The commonly used one-stage assays are based on APPT and compare a patient's platelet-poor plasma to the standard plasma, assessing the correction of APTT in the presence of factor deficiencies. These not only help confirm hemophilia, but also assess its severity. The chromogenic substrate assays use a mixture with excess factor X, activated factor IX, phospholipids, and calcium ions. It offers higher sensitivity for mild deficiencies. The journal article from the Nature Reviews Disease Primers also elaborates on how chromologic assays are the most reliable diagnostic test because it is less prone to interference by some other variables. Finally, although not a diagnostic test, genetic testing is often done with suspicion of hemophilia A, as it is often an X-linked genetic disorder. Pharmacological treatments for hemophilia A can be categorized into factor replacement and non-replacement drugs. The Nature Reviews Disease Primer journal on hemophilia A further breaks factor replacement into different categories: on-demand, primary, secondary, tertiary, and intermittent, which is shown in box 1 on the slide. This indicates when a treatment is initiated rather than what treatment is done. With bleeding episodes or on-demand therapy, factor VIII can be given to stop bleeding fast. Cryoprecipitate and fresh frozen plasma, or FFP, have been used due to their lower cost, but have experienced inconsistent viral inactivation of the product and inadequate hemostatic effects, making them less ideal than some of the newer options. Newer developments in the extended half-life, or EHL, factor concentrates have been very promising. Standard half-life F8 products typically last 10 to 12 hours, while EHL F8 concentrates extend this by about 1.5 times. There's also non-replacement therapies, with the most common being desmopressin and emicizumab. Desmopressin acetate, which can be administered intranasally, subcutaneously, or intravenously, increases F8 levels by stimulating the release of F8, von Willebrand factor, and plasminogen activator from endothelial cells. There is also emicizumab, which is a subcutaneous prophylaxis to prevent or reduce the frequency of bleeding disorders in people with hemophilia A. Emicizumab is an antibody that mimics the function of F8 by bridging factor 9 and factor 10, allowing the coagulation cascade to complete. Clinical studies reported in the Nature Reviews Disease Primers Journal article have shown that emicizumab significantly reduces the bleeding frequency in patients with hemophilia A. While breakthrough bleeds can still occur, the frequency diminishes over time. Aside from medications, it is important to focus on lifestyle modifications associated with hemophilia A. Preventing injury in the first place is one of the most important things for hemophilia A patients. The Journal of Health Economics and Outcomes Research published a journal article titled The Patient Experience of Living with Hemophilia A that presents qualitative research on various populations of patients and caregivers with hemophilia A. The study was done on males across the lifespan, with the majority being in the adolescent and young adult category. Because of the recessive X-linked nature of hemophilia A, males are much more likely to be affected than females. In addition, particularly in cases of severe hemophilia, infants and children are likely to be diagnosed due to episodes of spontaneous bleeding, while in more cases it may take until a severe injury or surgery occurs for an individual to be diagnosed later on. Finally, as we discussed on the last slide, cryoprecipitate and fresh frozen plasma may be selected as a treatment due to their lower costs, but are less effective and pose more risks than the newer drugs. Desmopressin acetate, or emicizumab, are the newer drugs that might not be affordable to patients in lower socioeconomic statuses. The same study from the last slide also provides information on how patients were handling living with hemophilia A. With appropriate treatment, patients with mild to moderate hemophilia A can expect a normal life expectancy. In cases of severe hemophilia, even with appropriate treatment, severe bleeding episodes can occur that can lead to other problems. This chart from the journal article goes into great detail of considerations for hemophilia A patients across the lifespan. Much of the comments from the patients in the study were regarding psychological limitations regarding the disease. Even with medication, the fear of bleeding causes significant stress. In addition, certain career opportunities that have a high risk of injury are not feasible due to the risk. Overall, although life expectancy can be normal with proper treatment, patients with hemophilia A must be well educated about their illness and make appropriate lifestyle modifications. Continuing with the article from the Journal of Health Economics and Outcomes Research, it was reported that children and their caregivers have indicated a need to adapt sports choices and noticed a feeling of being socially isolated and distanced from their peers. Majority of the teaching and guidance for a new hemophilia A patient surrounds lifestyle changes. Patients with hemophilia A should engage in non-contact activities to minimize the risk of injury. Safe options include swimming, cycling, and walking. Patients also must practice careful dental care to avoid gum bleeding. Regular dental checkups are crucial, and any dental procedures should be planned in collaboration with their healthcare provider. Using soft toothbrushes, flossing gently, and avoiding invasive dental work whenever possible are important to minimize bleeding risks. Aspirin and other NSAIDs, like ibuprofen, can increase bleeding risk and should be avoided. Instead, acetaminophen is often recommended for pain relief. It's vital for patients and caregivers to be educated on reading medication labels and asking their provider before starting any new medications. It's also important to educate on emergency medication use. Patients and caregivers should always have access to recumbent factor 8, which is essential for treating bleeding episodes. Education on when and how to use this medication is vital, including proper storage and administration techniques. These are my peer review references that were noted at the bottom of each slide where they were used. And these are additional references, including any images that did not come from the articles that were referenced. Thank you for listening, and I hope you enjoyed.